Adipose tissue is far more than a passive container for excess calories. It plays a critical protective role across the body by acting as a lipid buffer that shields vital organs from damage. In states of caloric abundance, when more nutrients are consumed than immediately needed, fat cells absorb and store these excess lipids in the form of triglycerides. This process is not pathological, it is a vital safeguard. Functional, insulin-sensitive adipose tissue acts as a biological sponge, soaking up circulating free fatty acids and preventing them from accumulating in non-adipose organs such as the liver, heart, pancreas, and skeletal muscle. This ability to contain and neutralize excess energy protects those organs from lipotoxicity, a condition in which inappropriate lipid deposition leads to inflammation, cellular dysfunction, and metabolic disease. The concept of adipose tissue as a metabolic buffer reframes the narrative about fat. Fat cells, when functioning properly, prevent harm elsewhere. They provide a safe storage site that keeps lipids out of harm's way. This function is particularly important in modern environments characterized by chronic energy surplus. Without adipocytes acting as lipid sinks, free fatty acids and other lipid intermediates would circulate unchecked, depositing in tissues not designed to store fat and impairing their function. In the liver, this leads to non-alcoholic fatty liver disease, NAFLD. In the pancreas, it impairs insulin secretion. In muscle, it reduces glucose uptake, and in the heart, it contributes to cardiomyopathy. The importance of adipose tissue's buffering capacity becomes especially clear in models where fat is absent or dysfunctional. In lipodystrophy, a rare condition where the body cannot develop or maintain normal fat stores, patients often suffer from severe insulin resistance, fatty liver, and dyslipidemia, despite having little to no visible fat. This paradox highlights a fundamental truth. It is not the presence of fat that causes metabolic dysfunction, but rather the inability to store fat properly. Without adequate adipose depots to sequester excess energy, lipids are forced into places they don't belong, resulting in metabolic chaos. In this sense, a well-distributed, healthy fat mass is protective, not harmful. Furthermore, the ability of fat to expand in response to caloric intake is itself a determinant of metabolic health. Healthy adipose expansion involves the recruitment of new adipocytes through adipogenesis, supported by adequate vascularization, extracellular matrix remodeling, and low inflammation. This adaptive process allows the fat depot to increase its capacity to store lipids without triggering stress or dysfunction. Studies have shown that individuals who can expand their subcutaneous fat tissue in a metabolically flexible way tend to remain insulin sensitive, even at higher body weights. In contrast, when adipose tissue loses its plasticity due to inflammation, fibrosis, or genetic predisposition, fat storage becomes dysregulated. The adipocytes hypertrophy excessively, become inflamed, and start to leak lipids and pro-inflammatory cytokines, initiating a cascade of systemic dysfunction. Interestingly, experimental data supports the systemic benefits of metabolically competent fat tissue. In animal models, transplantation of insulin-sensitive subcutaneous fat into obese or diabetic mice improves glucose tolerance and reduces hepatic steatosis. This rescue effect illustrates how a functional fat depot can draw circulating lipids away from other organs, acting almost like a metabolic shield. Even in humans, differences in fat distribution matter enormously. Visceral fat, deep within the abdominal cavity, is more prone to inflammation and dysfunction, while subcutaneous fat, especially in the gluteofemoral region, is associated with a lower risk of metabolic disease. This suggests that where fat is stored and how it functions is more important than how much is stored. Moreover, this buffering role of fat aligns with evolutionary logic. Our ancestors faced intermittent food availability, and the capacity to store energy safely for future use was a survival advantage. Adipose tissue evolved not just as an energy bank, but as a mechanism to prevent the overflow of nutrients into sensitive organs. In modern times, the same principle applies, albeit in the context of chronic caloric abundance. When adipose tissue maintains its buffering function, it continues to protect metabolic health. Only when it becomes saturated, inflamed, or fibrotic does it lose its protective properties. This perspective points toward a shift in strategy for treating metabolic disease. Instead of simply focusing on fat reduction, therapies should aim to preserve or restore adipose function. supporting adipogenesis, improving vascularization, reducing depot inflammation, and enhancing insulin sensitivity in adipose tissue may be more effective long-term strategies than aggressively shrinking fat mass. These interventions could help adipocytes resume their protective role, absorbing and storing lipids without harming the body. In sum, fat is not the enemy. It is the gatekeeper. Functional adipose tissue spares the liver from steatosis, the pancreas from SS cell stress, and the heart from lipid overload. It manages nutrient excess by sequestering it safely, shielding other organs from metabolic harm. This buffering role is not only essential, it is life-sustaining. The health of adipocytes may, in many ways, be the health of the entire organism.